So good evening, everyone. So I'd like to welcome our chairman of this course, Dr. Bipin Theruvil. He's a consultant from Lakeshore Hospital. Sir will be talking on total hip arthroplasty today. So let us all have a very good interactive session. Please feel free to raise any questions. Okay, sir. Over to you, sir.
Srinivas എന്നെ host ആക്കിയിട്ടുണ്ടോ? Sorry. No, that's fine. I was just checking whether I can share the screen. Okay. Guys, I think I want you to ask questions. I think this is a very informal session. Nothing very difficult here. This is a patient I have posted for tomorrow. Devraj, since you, let me just get the names there. Deepu, I know. Devraj. Jijin, where are you from? Okay. Who else is there? Naomi, where are you from?
Naomi from Amrita, sir.
Right. Okay. Okay. Yeah. Okay. Devraj, any?
Yes, sir.
Yeah. This is a 30-year-old male. He presents with right groin pain, and he's been on steroids for henoxonlin purpura. How do you proceed now? I'll ask you pretty much the same questions we asked in the DNB practicals.
We presented with right groin pain. Since it could be I'm thinking of an avascular necrosis of hip perhaps. So I have to, with only this much, this is my differential. And I would like to go for a clinical examination, look for hip range of movements, and ask him for further. Coming to history, I would like to ask him since how long has he got the pain, and what are the activity limitations that he has got, whether squatting and floor activities has been limited.
Yeah.
And
how does that help?
It helps in determining the degree of hip flexion. That is.
Okay. You think of AVN. What is the mechanism by which steroids cause AVN? Let's assume this is AVN. What are the mechanisms by which steroids cause AVN? The pathology. We all know steroids cause AVN. Anyone?
So it affects the circulation, blood supply to the coagulation of the.
In what way is the blood supply affected? I mean, what's the main blood supply to the femoral head?
Medial circumflex femoral artery.
Yeah, so you mean to say that, gets blocked like a heart attack. So if that were the case, we would be stenting each of these AVNs, won't you?
No, sir.
Yeah, so which it's called avascular necrosis. It must be for a reason. So how can it affect the blood circulation? Anyone? What are the proposed theories? I think most of these are controversial. What are the proposed theories behind steroid-induced AVN? Devraj or Shyam? Naomi, the only female of the group, or anyone else?
Yes, Naomi or Johnson?
Or Tadi Mohan is not teaching you well, is it?
Capillary circulation.
Yeah. You guys need to go and read it up. I think why steroid causes it. There are a number of proposed theories. It's including fat hypertrophy. You can have microvascular coagulatory disturbance. Just go and read it up about the pathology behind steroid-induced AVN. It's very, very important for you to know at least the hypothesis behind that. What are the other causes of AVN? Deepu.
So the most important cause is an idiopathic. And
okay.
Others are previous.
So others are not so important.
Yes, sir. I mean, the most common causes.
Yeah, most common. Okay, fine. Yeah.
So there's like previous traumatic causes like previous dislocation or displaced femoral fractures.
Yeah. Deepu, examination is, like I always tell to you, it's about classifications. You need to get them in some kind of order that you can find. And AVN is probably the hip pathology is probably one of the most common clinical cases. So you need to have some system. If you don't have any system, what can you use?
Okay.
Anyone watching Dr. House? Or any of these serials? If you look at it, you can look at this congenital traumatic, the surgical sieve, as we call it. So congenital traumatic, metabolic, pathologic, all those things you can look at. So what are the metabolic causes? What are the inflammatory causes? What are the infective causes that can cause AVN? What are the iatrogenic causes? Drug-induced causes?
So iatrogenic.
Drug-induced causes, any drugs that can cause AVN?
Yes, sir, like in this patient, steroids.
Yeah, steroids or what else? I mean, there is another drug, even though you don't call it a drug, there is another one.
Alcohol.
Alcohol, exactly, yeah. So if you don't know any of the causes, just go through the surgical sieve. So you look at the congenital, traumatic, infective, inflammatory, metabolic pathology. Inflammatory, what are the causes? SLE, rheumatoid arthritis, they're all, the vasculitis, they are all have been described to have, a risk of AVN. So just go through them, and you need to know the causes of AVN, in and out, because AVN is one of the most common cases that you will have in exam. What's the next investigation that you would order?
So MRI.
Yeah, right. Okay, that's fine. I think I'll go to the next case. This case is for actually, he was proven to have stage 3 AVN, so he is on the list for a total hip replacement tomorrow. And by the way, this is another question I asked all the DNB pages. Most of the guys could not understand, could not answer it. What is that circle doing there? Not Deepu, someone else.
It's a radio pic, because in order to know this reference, it's used as a reference.
Yeah, what is it used for? You are right. You are right. I mean, you are there. What is it used for?
It's used for checking the magnification.
Why do you need that? Why don't you? It's a digital X-ray, you can see if you just draw a line, you can see some markings there, 5 centimeter and all that. So why do you need this?
For preoperative planning, cup size.
Yeah, I mean, I think Naomi said is the right answer. It's to check the magnification, because whatever you read, if you just draw something on the digital X-ray, a marking will come, but that has got nothing to do with the magnification. This is to do with the magnification. So based on this, you can plan your cup size and stem size and all that. It's not perfect, but it is near there enough. Okay, we'll go to the next patient. Okay, this is a 16-year-old lady. She has acute lymphatic leukemia. Anyone suggest me? She has AVN, advanced AVN. Core decompression has been done. And core decompression, we know that it doesn't work in steroid-induced AVN. And what stage would you think that is? Anyone?
Stage 4. So,
yeah, it's a stage 4. Stage 4 is what?
So reduced joint space with arthritic, extensive arthritic changes.
Yeah. So what treatment would you offer her? She is 16. What are the treatment options that you could offer her?
Ultimately, she will end up in a total hip replacement. But
yeah, our teaching is about total hip replacement. You're absolutely right. Yeah, good. What are the other options you can answer? You can think of?
So first one is the pharmacological treatment, but it has only the role is controversial.
Yeah.
Alendronate, and the other one is we can try core decompression to buy some time.
Yeah. No, core decompression, like I said, in steroid-induced AVN, it doesn't work well. As you can see here, it didn't work at all. But you can try. You're fine. So Pharmacological, non-operative therapy, operative therapy. Operative therapy, hip preserving methods and hip sacrificing methods. So in hip preserving methods, you have got core decompression. What else can you do? Anything else? Can you do some form of
fibula grafting?
Sorry?
Fibula grafting, vascularized fibula grafting.
Yeah, vascularized fibula grafting along with core decompression is supposedly the gold standard. What are the problems of that, Naomi?
So,
Have you ever assisted one?
no, sir. No.
Yeah, I mean it's an absolutely painful procedure because it takes around 8 to 10 hours. Or I think in Amrita, those guys probably do it better. But normally it takes a long time, and you've got a fibula up the neck, and if you ever come to replacement, that fibula is in your way. It's not easy to. It will block your entry of the canal. So even though it's a gold standard, there are problems associated with that as well. So fibula grafting, yes, that is, you can say that. What else? Apart from core decompression for fibula grafting, any cell-based technologies you can use? Modern, these days, DNBs, they are asking all the advanced questions. That's why I'm asking you this.
BMAC injection.
Bone marrow aspiration.
No, BMAC is a technical term. It's a trademark. What did you say just now?
Bone marrow aspiration concentrate.
Correct. I mean, it's cell-based therapies. You can use one of those cell-based therapies, which are one is bone marrow-based ones. Then where else can you get cells? Can you, what did you say?
Plasma.
Sorry, placental?
PRP injection.
PRP injection has been tried. Yes, yeah, that's fine. But we are talking about stem cell, the cell-based injections. Anything else? I think you are right. PRP, bone marrow aspirate. What else? Anything from fat? Adipose-derived mesenchymal stem cells have been tried. Can you grow stem cells in culture? You can. You can do. You can take out the cartilage, grow it outside, and put it back in. So that's comes out by the trade name regrow and all that. So these have all been tried. So you've got various. You can do a core decompression alone. You can do core decompression along with bone grafting, which can be either vascularized or non-vascularized. You also have all those cell-based therapies, including bone marrow aspirate concentrate, adipose cell injections, where you take out a lot of fat from your abdomen and then concentrate it, put it back in, or you can grow the cells in culture. So those are the various options there. What else? Can you do an osteotomy here? Has it been described?
Varus derotation.
Yeah, you can do an osteotomy, or correct, Devraj. So what you do is right. So you can do an osteotomy to so that wherever the collapse is, you can rotate it out. So it depends on where the collapse is, whether you do want to a varus or valgus osteotomy. So that has been described as well. So these are the hip saving operations in general. So hip salvaging, the hip sacrificing options are which ones? 2 of them, or 3 of them rather. You generally think of every joint like that only. So you've got joint sacrificing, joint saving operations. So joint sacrificing, what are the 3 options in every joint?
Girdlestone arthroplasty.
Yes, correct. So you've got one is excision arthroplasty. Yeah. What else?
Excision arthroplasty, replacement arthroplasty.
Yes, very good. And yes, absolutely perfect. So you've got only 3 options in joint sacrificing. You've got girdlestone arthroplasty. What are the problems of that, Devraj?
Instability.
Yes, correct. Very good. And what else? The shortening, right?
Shortening.
Yeah. So you got instability and shortening. And what are the problems of total hip replacement at 16?
This is implant loosening.
Yeah, it can loosen in time. Correct. Okay. Well, problems of arthrodesis, the last one. or advantages, both disadvantages, both of them? Will it become loose if you've got a successful arthrodesis?
Degrees ROM.
Yeah, I mean, there is no ROM, so that's fine. Okay. What does arthrodesis do? Whenever a joint is stiff, what does it do to the next joint above or below?
Arthritic changes.
Yeah, I mean, there's something called as adjacent segment degeneration, very well known to the spinal surgeons, because whenever they fuse one level, they will have what is called as ASD, adjacent segment degeneration. The same thing happens. These are all linked joints. Whenever the hip is fused, you will have problems normally in the spine and also in the knee. Okay, so you will have degenerative changes in one joint or the other. So arthrodesis is also not the ideal option. So none of these are ideal options. Okay, so at 16, generally, most of us would hesitate from a joint replacement, but whenever the joint is this collapsed, most patients would prefer that in spite of whatever we decide. Okay, so this is a young girl who's had bilateral total hip replacements. So someone comment on what approach would you do a hip replacement in this one? Advantages, disadvantages. We'll just take through the entire part of total hip replacement through one case. Okay. Okay, Devraj, what approach would you do, and a logical reason why you would do that approach, and someone else who doesn't do that approach, tell me why you would do it through a different approach. Okay. Okay, Devraj, your choice of approaching this particular patient and why?
Hard
hinge approach, very good. It's a very good approach. So you would do a hard hinge approach, and what are the advantages and disadvantages of that approach?
Less chance of dislocation in hard hinge approach compared to posterior approach.
Okay, good. That's a classical statement. What else? Disadvantages?
Disadvantage, chance of abductor mechanism can be impaired with hard hinge.
What is the reason behind that?
We are disturbing the gluteus medius. We are dissecting the gluteus medius.
Yeah.
So the abductor pull. Gluteus medius is the main abductor muscle of the hip joint.
Yeah. So you are disturbing the gluteus medius. Any other reason? Is it got to do with the nerve at all? Which nerve supplies gluteus medius?
Superior gluteal nerve.
Superior gluteal nerve. And can you damage that, or how do you prevent to damage that?
Restrict the incision above the greater trochanter must be restricted within 5 centimeter. Good. Above 5 centimeter, there is superior gluteal.
That's very good. Someone else comment on some other approach you would do. So Devraj votes for lateral approach. Anyone else?
Posterior approach to it.
Okay, who's that? Deepu.
Yes, sir.
Yes, Deepu. Yes. So you would do a posterior approach. What are the advantages, disadvantages?
So advantages, it gives a good exposure to the acetabulum and also to the femoral shaft, while broaching the surgeon is actually in line with the femoral shaft.
So, yeah, you get a straight line down the femoral shaft, and piriformis is closer to your entry point. You're right. Okay, what else?
So like the average told, there is a chance for a dislocation, posterior dislocation of the hip, but it can be minimized by a careful repair of the short external rotator. So
okay.
There is not much incidence of the dislocation with the posterior approach also.
Correct. I mean, it's comparable provided you repair it well. So these two approaches, two good approaches, but you can do whichever. It's a question of a slightly higher dislocation rate with one side and a slightly higher Trendelenburg gate with the other side. Okay. Any other approaches, anyone? Any modern, better approaches? In DNB, I'm sure they are going to ask you this. Anyone else?
Sir, anterolateral approach or the Watson Jones?
Yes, that is there, but more modern approaches. I think anterolateral is Absolutely fine. What else? What are the other modern approaches to hip replacement? You know, there are hip replacements where you don't cut any of the muscles at all. Which are those?
Anterior.
Direct anterior.
Direct anterior. Manoj is replying through that. Manoj, you can speak directly. So what is a direct anterior approach? And what inter nervous plane or intermuscular plane does it go in?
So I think he has messaged, he has mentioned between tensor fascial lata and sartorius.
Okay, that's correct. Yeah, so it's going between the gluteal nerve and the femoral nerve. So he is absolutely right. So you got this direct anterior. Then you've also got what is called a superpath approach, where you go between the piriformis and gluteus minimus. Essentially, the same approach, you would go posterior, but slightly higher, but in between the muscles. So these are all described approaches, more minimally invasive approaches for early discharge and slightly lesser degree of instability because of less soft tissue disruption. So what implant are you going to choose? Exposure, we have decided one of these. Okay, what is the implant next? 16-year-old. Devraj.
Ideally talking ceramic on ceramic, but
no, ceramic bearing comes first. Go by the order in which you put in stuff. Okay. You are going to put in the cement, the femur first, or acetabular component first. So tell me what you will do it in sequence. Okay.
Sir, acetabular component first.
Yeah, fine. Okay. So with acetabular component, are you going to do a cemented one or an uncemented one? And give me a logical reason why.
Uncemented one, sir.
Yeah, why?
Younger age group, good bone stock.
Yeah. Then, you can do cemented also in the same age group. I'm not saying you're wrong. I'm just saying you defend your answer, because what are we all looking for? What is medical treatment for?
Bone integration.
No, medical treatment is for life. It's for extending your life. Okay, the whole medical fraternity, we are all here to make you or invest, live long. Okay, so we are all trying to lengthen we are trying to get the maximum longevity of the implant as possible. So yeah, so the whole thing is about getting you more miles out of your hip or knee replacement. So which implant lasts longer is the question.
Uncemented implant lasts longer, sir. Cemented acetabular.
Yeah, I think you are right. I think in a young patient, I would agree, uncemented implant lasts longer based on the literature. What about the femur? What would you choose? Anyone?
Sir.
I can even see Alagu in the list. Is it the same Alagu as we had in?
No, sir. He's a new PG.
Ah, right. Okay. I thought we had one, from who used to be in Amrita and then was in Medical Trust.
Yes.
Yeah.
This is a new one.
Oh, okay. Fine.
Okay.
Okay. Bhagiraj, you have been very quiet, or I'm going to pick out names. Jerry Gabriel. Vetri Venthan. Any of you guys? Tell us logical reason why we should use a cemented or an uncemented implant in the femur. Anyone? Based on literature. Deepu.
So both cemented and uncemented has comparable rates. So cemented replacement gives an immediate stability, sir, more rigid.
Yeah. Everyone agree with that? Devraj, since you are
a younger patient, I would think of uncemented.
Yeah.
Yes, sir. In this patient, I better to go for an uncemented femoral stem, sir.
Okay, why?
So the same reason as the acetabulum, there would be more loosening of the stem
if you are using a cemented one.
Yeah, over the years, and she will probably require she may require a revision also.
Yeah,
so even that will make it difficult.
Okay, fine. So I think this part, the acetabular side, it's the jury is fairly clear. Uncemented is better. On the femoral side, actually, cemented and uncemented give very good results provided you do it well. It's about the technique more than the technology here. So both of them do very well provided you use a good cemented stem like a polished tapered stem. It gives excellent results. Probably there is nothing to beat that as far as the results are concerned. But uncemented also, the present day uncemented stems give almost the same results. So it's still debatable. So I would not say one is better than the other. You can say both are equally good. Coming to the bearing surface, what would you choose? And why? And in your exam, you're going to be asked about it.
Ideally, ceramic on ceramic is preferred because wear and tear is low for ceramic.
What exactly do you mean by wear and tear? What wears and what tears?
Wear means during the movement there will be small particles are produced.
Yeah.
Which gradually the quantity of the small particle gradually increases with time and leading to loosening of the implant.
How does it lead to loosening?
There will be reaction, inflammatory reaction due to this particle.
Yeah.
It is called.
You're right. How does inflammatory reaction set in with these particles?
This wear and tear will act as an inflammatory mediators.
Yeah. You're absolutely right. I think they act like, especially if you take polyethylene particle, they are submicron sized. They look like almost the same size as a bacteria. So macrophages get fooled into thinking that they are bacteria. They are macrophages. That's a simplistic way of looking at it. The macrophages ingest them, and then macrophages start releasing all the interleukins and all that, so cytokines. They are all osteolytic, and that's how they get the osteolytic reaction. It's more with polyethylene. That's why ceramic and ceramic, the wear is less in ceramic and ceramic, whereas polyethylene has got higher wear. What are the ways of reducing wear in a polyethylene? How can we make it better?
Highly cross-linked.
Yeah, you can use a highly cross-linked polyethylene. You need to go and read up about how you make a highly cross-linked polyethylene. What are the different methods of doing that? What are the disadvantages of ceramic and ceramic?
So first one is squeaking problem that can happen.
You can have a noise. Yes, squeaking is a problem. What else?
And a fracture of the ceramic.
Fracture of the ceramic. How frequent is that?
Very less.
It's not that less actually. Most these ceramics are called delta ceramics. But still, I think there is about a 0.7 in 1,000. So less than 1 in 1,000. So it's not that less. So it's still there. So ceramic, the biggest problems are squeaking and fracture. And also, is it more expensive than polyethylene?
Yes.
It is.
Yes.
It is more expensive. Manoj has said about surface replacement. Good option. What are the Manoj? You can use talk or you cannot. You can only type. I cannot hear any of the other voices. You are all very, very silent. Are you all listening here, or you just kept it open? Is it? Bipin, can you hear me? Okay. Anyone talk about surface replacement? What's the bearing surface? And what do you do in this particular case? What is surface replacement?
Is Johnson? Shyam?
Probably they have not seen one. It's the typical example is something called as Birmingham hip resurfacing. So here we do a metal-on-metal replacement, and you don't put in a stem. You put in like you don't replace the entire neck. You don't sacrifice the entire neck. You replace only part of the head. Surface replacement works well in a CAM type of deformity, in an arthritis in a CAM type of deformity. This one with already advanced collapse, there is no hip to support a resurfacing. The hip resurfacing would not work. And as a what do you call a bearing surface, how good is metal-on-metal hip replacements in hip replacements? Metal-on-metal hips in replacements. Anyone?
Problem is adverse reaction to metal debris.
Yeah. Yeah, so you got problems with adverse reaction to metal debris with there, and a lot of people have had pseudotumors, dislocations, nerve damage, all that with metal-on-metal. So we don't do metal-on-metal total hip replacements anymore. Surface replacements are okay, but the indication is males with CAM type of deformity normally. We don't get it in India. It's common in the West. I have done a lot of them, but in India, we don't get that many. So we have very limited indications for surface replacement in our country. Anyway, this patient went with we did a hip replacement a year apart. She has got an uncemented hip replacement, and we did a ceramic with ceramic. But from an exam point of view, if you say uncemented, if a young patient, if you say an uncemented acetabulum, it's good, because my arguments would be uncemented acetabulum is good because intraoperatively, if you want to change the version, uncemented is better. And postoperatively, longevity-wise, uncemented is better in a young patient. On the femoral side, it doesn't make any difference. You can choose between the two of them. It's a surgeon's choice, because both of them give very good result. And bearing surface, ceramic on poly or ceramic on ceramic. It's really the surgeon's choice in a young patient like this. Any questions about this? In exam, you will be asked about it. That's why I'm saying. What's the offset of a hip replacement? Anyone?
So the distance between the center of the femoral head and the femoral stem.
Center of the femoral head and femoral stem. Everybody agree with that?
Horizontal offset and vertical offset.
That's right. I think you can say split it into horizontal and vertical offset, but most of the time we mean horizontal offset. So horizontal offset is the distance between that and between the center of the femoral head and center of the femoral stem. Okay, let's go to the next patient. Okay, so this is actually, she's not 40, she's 23. She's a 23-year-old young girl, has juvenile rheumatoid arthritis. What are your, she has been planned for replacement. Anyone read the X-ray for me, please? Quickly.
There is X-ray of the pelvis with both hips showing a severe osteoarthritic changes of the bilateral hip joint. There is a reduced joint space with the sclerosis of the femoral head. There is loss of the femoral head condor, and there is also a tilt of the pelvis.
Good. What else? Is it, what is the Kohler's line, Deepu?
Say ilioischial lines.
Yeah, very good. It's ilioischial line. And where is the Kohler's line in this patient? Is it what is wrong with that Kohler's line? So
breached, sir.
Sorry?
Kohler's line is breached.
Yeah, what does that mean then?
Protrusion.
Yeah, absolutely. You've got a patient has got a protrusio here. Everyone knows what is a Kohler's line. So Kohler's line is ilioischial line. I don't know whether where is it cone? So Kohler's line is ilioischial line. If it is if the femoral head gone medial to that, that means that the There is, what is the deformity called, Deepu?
Acetabular protrusio.
Yeah, it's called a protrusio. Okay. So what are the different, what is the angles that you draw for protrusio? So that's the Kohler's line, and the head has gone medial to that. What angle do you draw to differentiate a dysplasia from protrusio? Anyone? Not that difficult, is it? What are the angles that you do for dysplasia? Sorry? What is center edge angle? Anyone? Devraj, what is center edge angle?
From the femoral head to the acetabulum, to the superior margin of the acetabulum.
So, sorry, my computer is playing up a bit. What did you say, from where to where?
From the center of the femoral head.
Yeah.
And one line is drawn from the center of the femoral head, horizontal line, and there is another line drawn along tangential to the acetabular margin, superior acetabular.
Everyone agree with that? This time, our guys are all very quiet, is it?
Yes, so maybe once the exams are near,
they will become more silent, is it? No, you guys, this is a space for you to speak up freely. So anyway, that is the center edge angle. So how much would that be, you think? Around 70 degrees or so. So what is the normal center edge angle? What is it? When do you think of it as protrusio? What is normal? What is dysplasia? Because center edge angle is a very important angle. This is where you differentiate between protrusio and between dysplasia.
Less than 5. Normal is around 15, more than 15 degrees.
Yeah, normal is 20 to 40. You are right. So 20 to 40 is what do you call 20 to 40 is normal, and above 40 is protrusio. Below 20 is dysplasia. Okay, so let's get to the next slide. So what would you do for her? What are the challenges here?
There's a acetabular bone defect that we have to address.
Yeah. So she's headed for a replacement. So what are the things that from an exposure, what are the difficulties that you're going to face?
So dislocation of the femoral head will be difficult.
Yeah, I think you're absolutely right. I think your dislocation will be difficult. What else, to give you a clue? With these ones, you're at a high risk of leg lengthening, because ultimately you end up increasing the offset both on the acetabular side and on the femoral side. So lengthening is a problem. So essentially, the 3 commandments in protrusio you need to remember. You need to reinforce the medial wall by grafting. You need to restore the center of rotation, and you need to restore the offset. So here you can see all that graft medial to the acetabular wall is to restore that ileoischial line. I have done it quite well on the right side, but left side, I think probably I have overstuffed it a bit. These are cemented hip replacements. Even this is, like I said, she's a 23 or 24-year-old radiographer. So we have done a cemented femoral side, which, like I said, if you do it well, it lasts very long, as long as a uncemented hip. And we did a ceramic on poly because her acetabular, the ceramic on ceramic is available only from a particular size of acetabulum. So this one was too small, so we decided to go for a polyethylene. Okay, quickly, I think before we go, 2 more slides. What is this condition called? This is a patient who has come in with a trauma. He's had a hip pain for some time. Any volunteers? Anyone can read the X-ray?
Yes, Shinas, want to take it?
Sir, it's an X-ray of pelvis with both hip, with proximal third femur.
Forget about the femoral side. I know, but just concentrate on the femoral head and acetabulum. Forget the fracture is what I meant.
The joint line, the hip, the joint line is narrowed with the widened acetabulum on the right side compared to the left.
Yeah, good.
The teardrop is widened on the right side compared to left, and the Shenden's line is disturbed on the right side.
Yeah, good.
There is superior migration of femur head.
Yes. What with?
With dysplastic acetabulum.
Why do you call it dysplastic? That's a very good explanation. Why do you call it dysplastic?
Because on comparing to the left side.
No, I want scientific answer, not comparison to the left side. If you have got only one side, you will still call it dysplastic. Why? We just discussed it before.
Angle appears to be less than 20.
Sorry?
Center of the angle appears to be.
Correct. So you can talk about the center of the angle at this point. So, sorry, who was it answering?
The center of the angle is more than less than 20 here.
Yes, correct. I think that's the most important thing here. Center of the angle is going to be small here. So I don't know whether I can draw it. Okay, sorry. So you guys can eyeball it. You can see it's quite, sometimes works and sometimes. Okay, fine.
There is annotations on top.
I know. Yeah, no. My annotations, it's my computer, not you. It works sometimes, it doesn't. Yeah, I think the COS should sponsor a new computer for us. Hello, Balu. Yeah. So this is the center and edge angle. Both of them pretty much same place. So it's almost 0 degree, which means the center of the angle is 0. So that's a dysplastic hip. And what would you do for this patient?
Total hip replacement.
Why? Any challenges in total hip replacements in dysplasia? What are the classifications of dysplasia that you know of?
Arthroplasty.
Yeah, very good. I think that's very good. It's one is arthroplasty and one is crow. What is arthroplasty classification? That's fairly straightforward.
CROWE.
Yeah, CROWE. Yeah. Okay. Anyone with so Arthroplasty classifies into low and high, and Crow classifies from 1 to 4. You guys need to go and read it up. Okay.
Depending.
Yeah. So this has been treated with DHS. I'll just go through this is probably not important for you. So this patient comes, this one. What are the anatomical abnormalities in a dysplasia? Acetabular side, femoral side, what are the problems? Come on, guys, anyone? Acetabular side, you said it's dysplastic, so coverage is less. What are the problems on the femoral side?
Dysplastic femoral head.
Yes, good. So what does that mean for you when you're doing a replacement? It'll be small. Femoral component might be small. Acetabular component might be small. You might need to order in special components. What else? What happens to the femoral version? Is it normal?
Increased antiversion.
Correct. Increased antiversion. So you've got increased antiversion. You've got small acetabulum. You've got high acetabulum. And what else happens to the length of the leg? Shortening, lengthening? Shortening, yeah. These are all things you need to know when you are talking about dysplasia, and I'm sure these are all things for short notes for you. So that was this one. I'll just this. So the key thing for you in dysplasia, you want to place the acetabulum at the teardrop because that's the side of the breast bone stalk, and it improves the biomechanics, and also it gives you the best chance of getting the leg lengths right. And on the femoral side, you need to remember that the femoral version is it may be increased. You may have a small femoral canal. Some of these cases, you may even need to have to do what's called as a shortening osteotomy, like what you can see here. Quick question, two of them. This is a typical OSCE question. 70-year-old female, left groin pain. She has got an arthritic hip, spinal fusion 1 year ago. What's your major worry in this patient? When you're doing a hip replacement, what's your major worry with this history? Anyone? What happens, we talked about when the hip is fused, the spine gets the brunt of it. So what happens when the spine is fused?
The compensation.
Yeah.
The spinal compensation is not able
yes, spinal compensation. Yeah. So what? You are right. You are on the track. What happens because of that?
So here the acetabular version must be so correct for a successful surgery.
Yes, I think the thing is, whenever you're sitting, let's say you guys are all sitting on a chair now, and you are sitting at 90 degrees. 70 degrees of flexion happen at the, what you call the coxofemoral joint, at the ball and socket hip joint. And at least 20 to 30 degree happen at the, which joint? Where does it compensate? Which is the other joint that moves when you sit?
Lumbosacral.
Lumbosacral, at the L5S1. So what happens when this patient sits?
Only the hip will move.
Yes, only the hip will move. Only the hip will move, and the hip can impinge anteriorly and dislocate posteriorly in this patient if the spine is fused. So it depends on the, whether it's lordotic or kyphotic and all that. I don't want to go into too many complications of that. But as a PG, you need to understand that spinal fusion increases the risk of hip dislocation. That's a very, very, very topical topic as it were now. So you may be asked a question. And these patients, you need specialized standing and sitting x-rays to see how much mobility is there. And like someone suggested, I think we need to adjust the version according to the low doses. Some patients, we may need to increase the version if there is fixed low doses, or if it's kyphosis, you may need to reduce the version. And you may need to use what's called as a dual mobility hip replacement with these to reduce the dislocation. Everyone knows dual mobility?
Yes.
Good. Okay, one last question, I think, before we go. I think we'll wind it up shortly. Okay, let me just fast forward a few slides. Okay, I think Are you seeing my screen?
Yes, sir.
Yes, sir.
Yeah, I think let me just search one more slide. I think I've just missed it. Yeah, one last slide. Okay. You may think this is too much for your level, but I'll show you why I'm showing you this. Okay. As someone read this X-ray, this patient has come in with a RTA some 20 years ago, and patient comes with a right groin pain. Other than Deepu, anyone else? Anyone? Devraj? No, Devraj?
This is X-ray of pelvis with both hip, with proximal third femur,
yeah,
with malunited fracture of the ilium,
yeah,
and with pelvic diastasis.
Yes, good. You've got a pelvic diastasis.
And sclerotic sacroiliac joint right side.
Yeah. So you got a malunited. You think it's an open book injury on one side, and what else is the hip joint? Is the hip joint looking normal?
And arthritic joint.
Yeah, there is arthritic changes in the hip joint. So you got a non-union of the transverse non-union which is going across the ischial spine, arthritic joint, and an open book type of injury. So the reason I'm asking you this is this was a question asked for you in PG exam. Anyone of you see this question? Do you guys see the OSCE questions at all? Anyone answer this? This was an OSCE question this month. Because the answer to that is in the case I shown. So what type of THR is this? First question. It's the DNB this month's the latest DNB OSCE question. What type of THR is this? Question number one, point number one. Okay, come on, guys.
Uncemented total.
Uncemented on the acetabulum. Okay, and what about the femoral side? Is it cemented or uncemented?
Cemented.
Yeah, it's a cemented femur. So it's a hybrid type of hip replacement, right? And what else? I mean, what is that? In that right-sided dislocation, what is that ring that is seen?
Stabular cup rim.
You don't normally see that rim, right?
Yes, sir.
So what is that? That is something called as a ring of a constrained cup. This is a hip with a constrained liner, which is used in very extreme instability situations. So this one has dislocated in spite of that. In spite of that, a constrained liner has dislocated. What factors led? They have made a spelling mistake there. What factors led to early dislocation in this case? Anyone?
Excessive motion at the pelvis, especially in sacroiliac joint.
The sacroiliac joint is fused, isn't it?
Yes.
Okay. If you look at the cup from the front, if you ignore the left-hand side, or from the right-hand side, the pelvis looks like an AP view. Is that right? Just cover the replaced side. If you just look at the right side, the hip looks just exactly like an AP view, right?
Yes, sir.
Yeah. And if you look at the sorry,
version is
Yeah. So look at the left side. Version is, what do you think?
It is retroverted.
It's actually antiverted. It's very
Antiverted.
It's very antiverted. So what you need to remember is that the whole hemipelvis has rotated externally in a patient like this. So in a patient like that, you need to retrovert the retrovert the cup slightly to get better stability. You cannot put it in a normal version, then it will be unstable like in this patient. So what precautions will you take to prevent such an event in future?
Reduce the version.
Yeah, you need to probably reduce the version. You need to match the version to whatever that hemipelvis suggests. So this patient's hemipelvis has gone into retroversion. So you need to follow that retroversion rather than going into too much of antiversion. That is your answer to that. Not an easy question at all. I put it in our arthroplasty group, including most of your teachers, and most of us found it very difficult to answer that question. Actually, the reason I put it up is because you get such difficult questions, and the answer actually was this question probably came about because in the previous month JBJS there was a case report. I think Deepu, what was your idea? Deepu or PG wrote this report, and what did you find?
In cases like this where the hemipelvis is externally rotated, we should keep the cup in some degree of retroversion, which is an unusual position for an hip orthoplasty surgeon. So positioning of the cup in some degree of retroversion would give a good stability as far as this case is concerned.
Yeah, I think it's a very difficult one, but what I wanted to highlight is that these are, you guys are asked very difficult questions these days. So you need to really read up properly. Only then you will be able to answer most of these. In fact, many of these OSCE questions, I found it very difficult to answer. Okay, guys, I think we will wind it up there. Balu,
yes, sir. Yes, sir. Any burning questions?
I think probably the burning stomachs, I suppose. I think,
okay. So, sir, one quick question, sir. Now, where do we keep that lead ball marker when in the first case you showed, right?
Yeah.
We usually stick it at the trochanter level.
Yeah. The way I teach my PGs is how to learn it is to take a ball marker, take a torch pen, put that ball marker near your pelvis model, and practice how the magnification changes in the shadow that the torch, you can use your phone camera as a torch, and look at how the magnification changes. So the moment your lead marker comes towards your torch, it becomes very large on the floor. X-ray is exactly the same principle. So just practice it. The easiest way to learn it, take a pelvis, take a torch, take a ball marker, move it from anterior to posterior and see where it gives you the correct magnification. So in a patient, the correct answer is at the closest to the hip joint. And the closest to the hip joint would be at the level of the trochanter because you cannot keep it inside the hip. But if the patient already has a hip replacement, if you know the size or a hip replacement on the other side, that's the perfect template. So it should be at the level of the trochanter is probably the correct answer. But the way you learn this, the most simple way I can teach you is just take these three things: your mobile phone torch, take a ball marker, a pelvis model, see how it changes based on when your ball marker moves anterior and posterior. Very simple experiment, very nice to do.
Yes, sir. That is a very nice tip, sir.
X-rays are images, as you know. X-rays are shadows.
Yeah.
Okay, I think we'll wind it up there, Balu. I think thank you very much, guys.
Okay, sir. Thank you so much, sir.
Thank you.